Immunotherapy, also known as biological therapy, has revolutionized the treatment of malignant melanoma, particularly advanced or metastatic cases. It utilizes the body's immune system to recognize and attack melanoma cells, either by enhancing the immune response or targeting specific molecular pathways involved in tumor growth. Below is a detailed overview of its role. 1. Immune checkpoint inhibitors. Immune checkpoint inhibitors are a cornerstone of immunotherapy in melanoma. They target molecules that regulate the immune response, allowing T cells to recognize and destroy cancer cells effectively. A. CTLA4 inhibitors. Drug ipilimumab. Mechanism: blocks the CTLA4 protein on T cells, enhancing their activation and proliferation. Clinical significance: ipilimumab was the first checkpoint inhibitor approved for metastatic melanoma and has demonstrated improved overall survival rates. B. PD-1, PD-L1 inhibitors. Drugs nivolumab, pembrolizumab. Mechanism: inhibit the PD-1 receptor or its ligand, PD-L1, preventing the immune evasion of melanoma cells. Clinical significance: these agents are now standard first-line treatments for advanced melanoma due to their favorable efficacy and safety profiles. 2. Cytokine-based therapies. Cytokines are signaling proteins that modulate the immune response. Historically, they were among the first immunotherapies used in melanoma. A. Interleukin-2, IL-2. Mechanism: stimulates the proliferation of T cells and natural killer NK cells. Clinical use: high-dose IL-2 can induce durable responses in a small subset of patients with advanced melanoma. Limitations: significant toxicity and low response rates have limited its widespread use. B. Interferon alpha, IFN-A. Mechanism: enhances the antigen-presenting capabilities of immune cells and has direct anti-proliferative effects on melanoma cells. Clinical use: used as an adjuvant therapy in high-risk resected melanoma. Limitations: modest survival benefits and considerable side effects have reduced its popularity in the era of checkpoint inhibitors. 3. Adoptive cell therapy, ACT. This approach involves harvesting and engineering immune cells to attack melanoma. A. Tumor-infiltrating lymphocytes, TILs. Procedure: TILs are extracted from a patient's tumor, expanded ex vivo, and reinfused into the patient after lymphodepleting chemotherapy. Efficacy: has shown remarkable response rates in metastatic melanoma, including long-term remissions. Challenges: requires highly specialized facilities and personalized treatment protocols. B. Genetically modified T cells. Example: T cells engineered to express T cell receptors, TCRs, or chimeric antigen receptors, targeting melanoma-specific antigens. Status: still largely experimental, but holds promise for refractory cases. Oncolytic virus therapy. This therapy uses genetically modified viruses to selectively infect and kill melanoma cells while stimulating an immune response. Example: Talimogene laherparvec, TVEC. Mechanism: a herpes simplex virus engineered to produce granulocyte macrophage colony stimulating factor, GM-CSF, to enhance anti-tumor immunity. Use: approved for injectable, unresectable, cutaneous, and subcutaneous metastatic melanoma lesions. Combination therapy, often combined with checkpoint inhibitors for enhanced efficacy. 5. Cancer vaccines. Cancer vaccines aim to stimulate the immune system to attack melanoma by introducing tumor-associated antigens, e.g., GP100, MAGE-A3. Status: while promising in theory, most melanoma vaccines have demonstrated limited efficacy in clinical trials and are still under investigation. 6. Combination immunotherapy. Combining immunotherapy agents or combining immunotherapy with other treatment modalities has emerged as a strategy to overcome resistance and enhance efficacy. Examples: nivolumab plus ipilimumab, a combination of PD-1 and CTLA4 inhibitors, has shown improved survival in advanced melanoma, albeit with increased toxicity. Immunotherapy plus targeted therapy. In BRAF mutant melanoma, combining checkpoint inhibitors with targeted therapies, e.g. BRAF and MEK inhibitors, is under active research. Advantages of immunotherapy in melanoma. 1. Durable responses. A subset of patients achieves long-term remission. 2. Broader activity. Effective even in metastatic and otherwise treatment-resistant cases. 3. Synergistic potential. Can be combined with other therapies for enhanced outcomes. Challenges and limitations. 1. Immune-related adverse events, IRAEs. These include inflammation of organs such as the skin, liver, lungs, or endocrine glands. 2. Primary and acquired resistance. Not all patients respond, and some develop resistance over time. 3. Cost and accessibility. Immunotherapies are expensive and require specialized healthcare settings. Future directions. 1. Biomarkers for response prediction. Identifying biomarkers like PD-L1 expression, tumor mutational burden, or specific gene signatures. 2. Next-generation immunotherapies. Development of novel immune checkpoint inhibitors, personalized cancer vaccines, and new AST modalities. 3. Combination strategies. Continued exploration of synergistic combinations with radiation, chemotherapy, or targeted therapies. Conclusion. Immunotherapy has transformed the landscape of melanoma treatment, offering hope to patients with advanced disease who previously had limited options. As our understanding of tumor immunology deepens, further advancements in immunotherapy are expected to improve outcomes for melanoma patients.